Thank you very much for your collaboration with this Skype lecture. You have all your time now, the 45 minutes if you want, and then some time for discussion. Go ahead, thank you.
Hello, everybody. I'm really sorry that I didn't manage to come over. My name is Chiara Robba, and I work in Italy, in Genova, so not far away from Porto, and actually Genova is very similar to Porto. That's what I have been told, at least. I've never been there. So the title of my presentation is very straightforward, but I think that the first slide actually says everything, because at the end, after all, what we really need to look after is that our brain and the brain of our patients is actually well oxygenated. So brain oxygenation is what really matters. And this is basically the agenda for the next 40-45 minutes. So basically we are going through the pathophysiological principles of cerebral oxygenation, and we are going to discuss which is the best way to monitor and optimize the cerebral oxygenation in order to prevent brain damage and secondary brain injury. And we need to have a think, I believe, because when we give a general anesthetic, we normally monitor our patients from any point of view, from the systemic point of view. So we monitor the cardiac function, we monitor strictly the respiratory system, we monitor the renal system and whatever, but actually, very rarely, we monitor the brain. But I don't think that this is actually the best idea, because the main target as anesthesiologists should be actually the brain. And also, we have to think that the drugs that we use and the technique that we use in our patients primarily affect the brain. Some or a huge number of patients that we anesthetize are patients with brain injury, subarachnoidal hemorrhage or traumatic brain injury. Also, there are some group of patients who are basically at risk for brain injury, such as the elderly patients who are very vulnerable to the effects of the general anesthetic on the brain. So these are all the things that we should keep and take in account. So the question is how to monitor our brain. So these are a lot of options. We have actually a lot of options. We can monitor, for example, the intracranial pressure or the cerebral perfusion pressure, which basically are giving us an idea of which is the driving pressure of the blood, which is in the flow, which is delivered to the brain. We also have non-invasive methods. For example, the transcranial Doppler, which is an indirect measure of the cerebral blood flow, which is able actually to give us information about the local cerebral blood flow and the regional cerebral blood flow. And then we have all the monitoring, and that's the main part of our symposium, which are going actually to describe the oxygen delivery and the oxygen consumption, such as the SpVO2 or the NIRS or the PbO2. And then we have neuromonitoring methods, which basically are describing which is the metabolism of the brain, including, for example, the microdialysis. And least but not the last, obviously, the EEG, which basically is able to tell us how is the CNS function and the electrophysiology of the brain of our patients. So we have actually a lot of options, and all these neuromonitoring techniques I believe are complementary. I mean that there is not an ideal neuromonitoring technique, but each one of these techniques is actually able to tell us something, a part of the pathophysiology of the brain. So let's talk a bit about pathophysiology. I'm sorry, I am a bit boring, but we talk about pathophysiology. It's all about an equilibrium between the cerebral supply and demand of oxygen. So if we have here our brain and the brain circulation, we have an arterial compartment and a venous compartment. So what does happen? When we are in a condition of a normal cerebral blood flow, okay, we have an inflow, which is the arterial compartment, which delivers blood to the brain, and afterwards, basically, this basically presents a 100% of oxygen saturation. So a lot of oxygen, which is delivered to the brain, it's supplied to the brain, and the brain uses it as a substrate. And then it is basically shipped to the venous compartment after it's been metabolized. Of course, the venous compartment in the jugular vein contains a lower amount of oxygen, so the saturation here is around in 75% in normal conditions. So it's all about coupling between the cerebral blood flow and the SCMRO2, which is the cerebral metabolic rate of oxygen. So in normal conditions, so in normal physiology, CBF and CMRO2 are actually going together. It means that we are coupled. So when there is an increase of the cerebral blood flow, the cerebral metabolism rate is increased as well, with a low cerebral blood flow and both with a high cerebral blood flow. And if they are coupled in this situation, what we obtain here is a status of hypermetabolism and hypometabolism. But when basically they are discoupled, like in this case, or in this case, or in this case, or in this case, something bad happens, because when we have an increase of the cerebral blood flow, but no increase of the metabolic rate, what happens is that basically we have a sort of situation of hyperemia. And on the other hand, where the metabolic rate is higher than the cerebral blood flow, what we obtain is a cerebral ischemia and therefore a secondary brain damage. So this is basically what we need to avoid. And to do this, the only thing that we can do, the first thing that we can do, is actually to measure the cerebral oxygenation. And these are the options that we have: jugular bulb oximetry, tissue oxygen probes, and cerebral oximetry. Here you have three nice pictures of all the methods, and we are going to start to discuss the jugular bulb oximetry. You probably know this method. It's it's a very old method, more than 20, 30 years ago. So basically, this is the normal anatomy of venous flow. So as you can see here, basically, the oxygenated blood from the brain is collected by the major cranial venous sinuses, especially the sigmoid sinus, the superior petrosal sinus, and the cavernous sinus. Okay, and these basically follow a curved path in the posterior fossa, and they pass caudally and forwards and they arrive at the internal jugular foramen, which is here. Okay, so basically, this technique is based on the sampling and on the percutaneous sampling and analysis of the cerebral blood flow, of the cerebral venous flow here in the jugular foramen and in the jugular bulb, which is here. Okay, so the concept is that the venous difference between different substrates like the oxygen, the glucose, and the lactate is reflected global measure of the balance between the cerebral demand and the cerebral metabolic supply of the brain. Now, of course, you will have to imagine that if we sample the blood here, so below the facial vein, we actually have a contamination from an external component of the venous flow. So one of the major determinants and one of the most important components in this kind of technique is the position of the probe. So this is the normal anatomy. So we have again our external jugular vein, and this is a check. So basically after the insertion, which needs to be a retrograde insertion, we need, using the neuroimaging, to assess the position of the catheter tip, which needs to be above the superior border of the C1 vertebra. So how does it work? This is basically still pathophysiology, sorry again, but basically the oxygen saturation that we find and that we can measure in the jugular bulb is related to the cerebral metabolic rate of the oxygen, and this is a very interesting formula. So the metabolic rate is directly correlated to the cerebral blood flow, and the difference between the oxygen in the arterial compartment and in the venous compartment. So to make things a bit easier, you can have a look at this drawing. So this is in normal condition with normal cerebral blood flow, SATs of 100% in the arterial compartment, SATs of 75% in the venous compartment with a normal cerebral blood flow and a normal extraction of the oxygen. Okay, the extraction of the oxygen is basically here, which is the arterial venous oxygen difference, and it's a measure of the ratio between the metabolic rate and cerebral blood flow. But when we are in a condition of a reduction of the cerebral blood flow. You see that now it's reduced, it's 25 ml per 100 gram per minute. What happens is that the delivery of the oxygen is 100%, but the brain is going to extract much more oxygen. So at the end, what we will see is that in the venous compartment, we have a reduction of the saturation of the oxygen. Okay, so according to the literature, basically, a reduction of the saturation in the jugular bulb below the 50%, 50-55% corresponds to an increase of the extraction of the brain, and it's the threshold which is actually related to the critical ischemia. So, just to summarize, the technique is a reverse incannulation of the jugular vein. The sample can be continuous, can be also intermittent. The normal values should be around the 65%, but we consider episodes of desaturation, or basically the threshold for ischemia around the 55%. This is a technique which has been reason for several discussion and debate because it has several limitations. First of all, the first debate was basically about where to put the catheter, on the right, on the left, or bilaterally. And basically, what we obtain from this technique is a global measure of ischemia. So it's not actually sure which is the best place where to insert the probe. For sure, if you have a monolateral lesion, it's probably better to monitor the damaged hemisphere. Of course, another limitation is that this technique measures the global desaturation, but not regional desaturation. And we know, and we are going to discuss it in a few minutes, that basically what we want to know is how is a very initial sign of cerebral deoxygenation to assess basically what happens in the penumbra zone, which is the first part of the brain which is at risk to be damaged according to the secondary brain damage. And then the third but very important issue is basically the extracranial contamination, especially for the facial vein, and the main issue here is basically the position of the probe. So, how can it be used? It can be used, of course, to estimate the cerebral metabolism. It can be used to guide interventions, for example, the hyperventilation. It can be used to assess the outcome of the patients. Episodes of desaturation below the 55% are actually associated with a poor outcome. And this is demonstrated in several brain injuries, including traumatic brain injury patients, but even in patients with not a primary brain injury, but in patients who undergo procedures which are at risk of cerebral complications, including the cardiac surgery. This is, for example, a very nice study from Robertson et al. It's pretty, it was performed in 1999, so long time ago, but still a huge number of patients were included, 177 TBI patients. And basically the information that we have from this study are that, first of all, that episodes of desaturation in TBI patients are very common. They occur in nearly the 40% of the patients. And second, that the number of the episodes is strictly related with the outcome. As you can see, a patient who does not have any episodes of desaturation has a risk of death of the 21%. If you have more than one episode of desaturation, the percentage of death is up to the 69%, because it is actually correlated with the secondary brain. So there are several conditions that then obviously can decrease the values of SGO2 or increase the values of SGO2. For example, there are conditions of reduced oxygen delivery or increased oxygen consumption, which both can determine a decrease in SGO2. When can we have a reduced oxygen delivery? When we don't have an appropriate cerebral perfusion pressure, when we have systemic hypotension, anemia, sepsis, arterial hypoxia or vasospasm or whatever, or also we can have a situation of increased oxygen consumption, for example in hyperthermia, inadequate analgesia, increased need of oxygen, increased cerebral metabolism, seizure, etc. There are also conditions where basically we have an increased values of SGO2, And these are basically related to increased oxygen delivery, arteriovenous malformation, for example, vasodilation, or in excessive cerebral perfusion pressure, or where you have basically a reduced oxygen consumption, like in hypothermia, coma, or the use of different drugs. So this is a nice algorithm which has been proposed 18 years ago, 10 years ago. But basically, the authors here suggested what to do when we see impaired values of SGO2, so above 75% or below 55%, but even what to do and what's the reason behind the even normal values and physiology. And as you can see here in this algorithm, basically, the first thing to optimize is basically the map and then the ICP. Of course, in a patient who has got an SGO2 above 75%, the main problem won't be the map, probably, because the patient is in a condition of hyperperfusion, probably, and so we need to treat the ICP. But in all the other conditions, the first determinant of SGO2 is basically the delivery of oxygen and therefore the MAP. So MAP and ICP should be considered together, but of course, all the MAP consideration should take a priority. This is another study which basically studied the effects of different general anesthetics, so isoflurane, sevoflurane, and propofol on the episodes of SGO2. Patients were undergoing general anesthesia during artery bypass surgery. And basically what they obtained is that what they saw is that the main episodes of desaturation occur after 1 hour, and especially using the propofol, probably related to the reduction of the systemic blood pressure. So again, the main determinant for the SGO2 in this case is as first cause the hypertension and the reduction of the cerebral perfusion pressure. But we need to be careful because this is the relationship between the SGO2 and the percentage of brain volume. So if we have a look at this line, what we see is that here, when we are at our critical threshold of 55%, we have already a loss of 17.5% of the brain. So when we see a value of 55%, it's already a bit late, and it's something that we can, and the treatment should not be delayed, because at this point we have already lost an important amount of cerebral tissue. And then we go forward and we discuss a bit about the brain tissue probes. So these are probably the most used at the moment, together with veneers. Brain tissue probes have one disadvantage. The disadvantage is that basically they are invasive. This is what we in Cambridge and now in Genova are starting to use, which is basically the triple bolt, which is a bolt, so an invasive intracranial pressure monitoring, where there are 3 ways of access. One is the ICP, one is the PbO2, and one is the microdialysis catheter. And so basically this is the PbO2 catheter, which is based on the Clark method, and this is the machine where basically you obtain the values of the PbO2 and the temperature of the brain. So it's based on the fact that the flux of oxygen, which is in the extracellular compartment, arises and is determined from a concentration gradient that is maintained and is the result of the supply and the consumption of the oxygen at the capillaries and at the brain capillaries. So if you think about this, and if you think about the slides talking about the physiology before, the average extracellular oxygen tension reflects the equilibrium between the delivery and the consumption of oxygen, as well as the nature of the diffusion barrier, which enables the oxygen to arrive to the brain. So again, even in this case, the location of the catheter is very, very important. Generally, this is placed by a neurosurgeon, and basically it depends on the type of intracranial pathology. In traumatic brain injury patients, for example, if we have a diffuse injury, the probe is generally located in the right frontal lobe. If you have a focal injury like contusion or a subdural hematoma, the best place where to put the probe is in the pericontusional tissue, because it's the place where most likely, if something happens, the first metabolic derangement occurs. And in subarachnoidal hemorrhage, it's a bit more difficult because the probe should be positioned in the part where we mostly think that there is the higher risk for stopping vasospasm or delayed cerebral ischemia. So the position of the probe could be checked by both a non-contrast SCD scan, and it looks like here with the ICP and the PbO2 probe, or using an FiO2 challenge. So basically we can just increase the FiO2 to 100% for a few minutes, and we see if there is a concomitant increase of the PbO2. So again, summary of the characteristics. It's an invasive method. It's based on a Clark type electrode, which basically measures the PbO2. The machine is called LECOX, which enables to assess and to measure PbO2 and the temperature. It does not give a global idea of cerebral ischemia, but just a highly localized measurement. The problem is the threshold. Generally, we accept a threshold of 20 millimeters of mercury, but as we will see in a few seconds, there are different thresholds which have been studied and which have been discussed. And again, even for the jugular bulb saturation values, low values of PbO2 have been associated with poor outcome in brain injury patients, especially in TBI patients and in subarachnoidal patients. So this is an example. So this is a paper which basically includes more than 30 patients, and what the authors try to do is basically to assess which are components that are related to episodes of cerebral hypoxia. And these are actually the statistically significant results. So the blood pressure, of course, so hypotension is related to hypoxia, good so far. Pulmonary hypertension, so ICP above 20. Cerebral perfusion pressure, so below 60 millimeters of mercury, and an FiO2 below 0.6. But if you have a look at this graph, which is pretty important, here you have the PbO2 values, 10, 15, 20, and here there is the risk for poor outcome. And as you can see, when the cutoff for the PbO2 is actually 20 in this case, and the risk of that increases dramatically when basically we have a reduction of the values below 20 millimeters of mercury. And this is another example, another paper, which is discussing basically the relationship between cerebral hypoxia and outcome. In this case, the author studied the cerebral oxygenation in the first 72 hours after brain injury. And these are actually the results. And again, if you see this graph, basically, values of PbO2, lower values of PbO2 were found in patients who died, and higher values of PbO2 were found in patients who survived. So it's actually correlated with both the mortality and also with the neurological outcome. The only concern in this paper is that the threshold here is very high. So PbO2 threshold was related to 29 millimeters of mercury, which is basically very high considered and compared to other studies. Because if you see here, these are the main studies which basically correlate PbO2 values to the outcome. Here, GOS at 3, 6 months, or even morbidity and mortality. And as you can see here, the threshold, they basically go from 10 to 25, and the accepted threshold in general is basically 20 millimeters of mercury. Now, which are the determinants of cerebral oxygenation and PbO2? This is a very, very nice paper, and I believe that all the physiology could be described in just this draft. So basically, this is a study performed on a huge number of patients, where more than 100 measurements were taken of PaO2, so systemic PaO2, arterial oxygen content, venous oxygen content in the jugular bulb. venous oxygen content, as well as the measurement of the cerebral blood flow and the cerebral metabolic rate. So basically, among all these parameters studied, the parameters which were actually directly associated with the PbO2 were brain tissue oxygen tension, were the cerebral blood flow, and the difference between the arterial and the venous PRP. So this means that the main components are again cerebral blood flow, so the amount of blood which actually arrives to the brain, and the diffusion of the dissolved plasma oxygen which passes across the blood-brain barrier. These are not actually the only components which are important in cerebral oxygenations. There are also several systemic components which are important and need to be taken in consideration. One of these, of course, is the systemic oxygenation and therefore the occurrence of lung injury. So in this paper, basically from Mauro Oddo, patients were divided according to the PF range, so above 300 or below 300, so severe, moderate, or mild ARDS. And basically what they found is that the cerebral oxygenation is obviously correlated with the PF range. So it's not just about cerebral metabolism, it's of course obviously about systemic oxygenation and the amount of oxygen which is actually delivered to the brain. And this is another paper, so another question. Any other components, any other factors which can influence the cerebral oxygenation? Well, the anemia, of course. This is a study which included 20 patients with subarachnoidal hemorrhage who underwent multimodal neuromonitoring, so cerebral microdialysis, oxygen tension, etc. The authors actually assessed that 4 different levels of hemoglobin, which were the values of PbO2, considering patients with normal or basically stable cerebral blood flow. This is what they found basically. So values of HB below 9 grams per deciliter are associated with hypoxia. So again, even though it's always difficult to find a threshold for the use of blood components, according to this paper, basically the threshold in order to avoid the cerebral hypoperfusion and cerebral hypoxia is basically 9. So this is a summary. The PbO2 values are obviously directly correlated to the cerebral blood flow and the differences between arterial and venous PbO2. And the main component, the main part which are actually related to cerebral hypoxia are a reduction of the cerebral blood flow and CPP, a reduction of the PaO2, so of the systemic oxygenation, a reduction of the oxygen transport, so the values of HB, and an increase of the barriers to the oxygen diffusion. So when there is a damage to the brain-blood barrier and the oxygen is actually arrives, is delivered by the arterial component, but it's not diffused to the cerebral brain parenchyma. So, which is the clinical utility of PbO2 monitoring? First of all, the CPP management. So, if we have understood physiology, we now know that what we need to do is to maintain an appropriate MAP target. Not just an appropriate MAP target, but to assess which is the individual CPP target, which is the target at which the patient is autoregulating best. Of course, in this case, we'll see it in a second, the induced hypertension in subarachnoidal patients is of great importance. Obviously, we need to control the ICP, the intracranial pressure, which is actually related to the PbO2 in the brain. We need to be careful about the hemoglobin threshold for blood transfusion, and we need to be careful about the systemic oxygenation, so PF ratio, PEEP, the optimal PbO2 target, etc. This is an example of use of PbO2. This is a software which is called ICM Plus. As you can see here, it is actually able to show ADP and CPP together, okay, in the first panel. Here there is basically the ICP. This is the PRX in green, which is the autoregulatory index. And if you see this funnel here, this means that when it is red, the patient is not autoregulating properly, and when it is green, it means that the patient is autoregulating properly. And in the last part, we have our PPO2. So if you have a look here, what happens is that at some point there is an increase of the intracranial pressure with a concomitant decrease of the CPP. And what happens is that the PRX increases, which means that it becomes red. So the patient is not autoregulating properly. And if you see the values of the PbO2 here, they just drop below the 20 millimeters of mercury. This is another example. This is a patient where this is the normal. This is our ICP, which displays basically a reduction of the compliance between the P2 component is higher than P1. And here we basically have in red the CPP here, our ICP here, and in a second we will see the PO2. So what happens here is basically that there is an increase of the ICP and a reduction of the CPP. And have a look at what happens to the PbO2. So it is above 2025, and at some point it drops, and is actually very concomitant with the reduction of the CPP. They basically go together, and when you have again a reduction of the ICP and an increase of the CPP, the PbO2 comes back to the normal values. So it's strictly correlated with ICP and cerebral perfusion pressure. So this is an example, for example, in a patient with subarachnoidal hemorrhage. This is our PbO2. This is a CT perfusion which shows reduction of the cerebral blood flow with cerebral blood volume, which is actually maintained with an increased mean transit time. Calling it, this means that there is an area of vasospasm with the penumbra area where the cerebral blood flow is reduced, but the volume is increased. So these are the values which had been detected before starting the vasopressors. So low values of PbO2, low values of CPP, and this is what happens when we increase the vasopressors. So the CPP increases and the PbO2 increases. Again, this is an example. Basically, CPP and PbO2 are often going together. And it's exactly what is expressed in this paper, which is the very famous paper by Munk et al., where basically patients are treated with vasospasm and after subarachnoidal hemorrhage are treated with just hypertension, with hypovolemia and hemodilution here, or with hypertension plus hypervolemia and hemodilution. So as you can see here, the main component, the main statistically significant component to increase the PbO2 is basically the hypertension, which is able to improve the PbO2 alone, and the addition of hypervolemia and hemodilution here does not make a very huge difference. And that's the paper according to which we now basically use the hypertension as first line treatment in case of vasospasm. And again, the other, this is another paper from Pierre Bulzat and Mauro Oddo again. They basically studied cerebral hypoperfusion after traumatic brain injury. This is a ROC curve, which basically is telling us that the use of the PbO2 together with the ICP is much more reliable here. You can see it here, rather than use of ICP alone to detect cerebral ischemia and secondary brain injury. So actually PbO2 is something really important. Last part, oximetry. Cerebral oximetry, which I hope you will see this afternoon in the workshop. Again, I'm really sorry that I won't be physically there. These are the physical principles. So the biological tissues contain a number of structures which are pigments and which are able to absorb the light. Some of these are, for example, the hemoglobin, which has got a specific absorbance spectrum. So when we use near infrared light, normally we use it between the 700 to 900 nanometers, where the absorption from skin and bone is very low. Basically, what we do is to measure the optical absorption at different wavelengths, and it depends, and the absorption depends on the relative concentration of these pigments, so for example of the hemoglobin. So at the end, what we obtain is a measure of the oxygen delivery and consumption. It's similarly from the pathophysiological point of view, the SJVO2, but it does not require any invasive catheter. These are again the physical principles. So there is a first phase, which is basically the emission. So a white beam source basically emits a light with several wavelengths here, and then what happens is that there is an incident radiation which arrives at sample analysis, and the part of this wavelength is absorbed here according to the number of the pigments, and the part of this is then transmitted. And when we transmit the radiation, there is a zone of detection which is actually able to tell us which is the spectra of the wavelength which have been absorbed and which of these have been transmitted. So it's basically based on the Beer-Lambert law, according to which basically the absorbance of the wavelength is directly proportional to the molar absorbability, to the path length of the sample, and we'll discuss it in a second, and the concentration of the pigment in the solution that we are where we send our incident radiation. So theoretically, we can measure the concentration of a single chromophore or of two different chromophores. So to do this, we have to perform absorption measurement at a different with a different number of wavelengths, and because what the dominant cerebral chromophores in the brain are actually oxygenated, and the oxygenated hemoglobin, they have very different near-infrared absorbance spectra. So basically, we can discriminate and we can assess the amount of oxygenated and the oxygenated hemoglobin. Of course, when we do it, it's non-invasive. We'll see the picture in a second. We need to consider that the 75% of the cerebral blood flow is venous. So basically, what we obtain as first information is basically predominantly the venous oxygenation, which anyway reflects the oxygen extraction. So as I was telling you before, one of the main determinants and one of the main issues of this technique is the path length. So here we have our light source here, and these are here basically the light is transmitted and needs to arrive here. This basically detected. Now, if we think about this, if we have a look at this picture, we need to consider that the incident protons penetrate the scalp here, the skull and the brain, and they travel in a path which looks like a small banana, let's say, but the depth of this makes that what we obtain is signal which comes even from the skin, from the tissue, from the bone. So this can determine a sort of contamination. And the other problem is that from the light source, not always the banana shape is preserved. So basically we can get information about extracranial components, or basically something that we do not want to obtain. But in general condition, this is the machine which we are going to use this afternoon, and basically which is able to give us real-time information bilaterally, right or left here. This is the position of probes here. This is basically what we can detect at this time. So two light sources and two detectors for each size. So similar function to the SJVO2, it's not invasive. The normal values are basically compared to the SJVO2. As we have seen, there are some limitations which are actually related to the extracranial contamination, as well as systemic issues, including the HPV levels, the CPP, the microcirculation in the skin, etc. Again, is exactly like for the SJVO2 and the PbO2, episodes of desaturation below 50% are associated with poor outcome. And this has been studied, especially in patients with no brain injury. The normal values are basically above 55%, but in healthy volunteers, these are two studies. One was performed in 1998, and the mean value was around 67. This study found values a bit higher, 75.48 plus or minus 5.95%. But basically, what we need to achieve is to have a constant values above 55-60% in this patient, and it also depends on the initial values of saturation, because it's not probably such important as a number, but probably as a trend. Which are the determinants of reduced cerebral oxygenation? Again, very similar to the other methods. So reduced oxygen delivery, anemia, CPP, hypotension, we already discussed this. So the pathophysiological mechanism is basically the same, or an increase of the oxygen demand, pain, hyperthermia, and especially the presence of seizures. And this is a paper which basically went to study which are the components which are actually correlated with low values, or which actually affect the values of the cerebral saturation. And again, we have the hemoglobin concentration, not surprising at all, the area of the cerebral spinal fluid layer, and of course the skull tip thickness, okay? And this is actually, again, what we were discussing before about the path, and the path that the waveform needs to go through. Obviously, in patients with brain injury and neuro ICU, we need to be really careful before we start this kind of monitoring, because, for example, this is a patient with bilateral hygroma. So in this case, we won't be able to detect the cerebral oxygenation in the parenchyma. And similarly, here where we have air, so pneumoencephalus, or here where basically we have the blood. So again, the position of the sensor is going to be very, very important. So we were mentioning before about the effect on the outcome. NIAS has been studied largely in patients during cardiac surgery. The question in this paper, 2009, huge number of patients, is whether cerebral regional oxygen saturation can improve the clinical outcome in these patients. So patients who did not have any neurological injury before the surgery, but of course we know that during cardiac surgery there are several phases which are actually associated with the risk of neurological complications. So this review included more than nearly 500 papers, both in pediatric and adult population, and these are basically the conclusion. The intraoperative oxygenation monitoring is useful, is feasible, and it's available. And basically the interventions guided by the oxygen saturation are associated with a reduction of neurological injury and shorter hospital stay. And of course, this is a technique which does not have contraindication because it's not invasive and it's not harmful for the patient. Again, this is another study which has been performed determining the cerebral oxygenation values in patients with cardiac arrest. So the question here is whether it's feasible or helpful to predict the return to spontaneous circulation, and these are actually the results. So 19 hospital cardiac arrest patients, of these 5 at ROSC. These are the results. First of all, this method is feasible, so it does not interfere with resuscitation or the clinical management, which is already a very important message. And the patients who had the ROSC had significantly higher overall values of cerebral oxygenation. So probably the use of NIAS in this case would potentially have a role to optimize and assess the cerebral perfusion during cardiac arrest. And these are basically the results. I'm not sure how much confident you are with the statistics, but these are the mean values of cerebral oxygenation in non-survivor, and these are the mean values of patients who survived, and there is a statistically significant difference, and this difference is even higher in the last 5 minutes before the ROSC, so in the latest part of the resuscitation management. Now, the question is whether all these 3 methods can be compared or they do agree one to each other. This is a paper which compared the agreement between the SJO2 and the NIRS. A lot of patients, but here basically what we found was a poor correlation here. This is the coefficient correlation, with basically wide limits of agreement. So not comparable SpO2 with NIRS. What about the NIRS and the PbO2? Again, the authors here found some methodological issues because many patients, nearly the half of the patients were excluded because of problems with the technology like frontal hematoma, wounds, intracranial lesions, which precluded the use of the NIRS. This is probably the main issue in the use of this technique in neurocritical care. And again, anyway, the correlation is actually poor with a wide confidence interval. So we are at the end. I hope you are not too bored, and I think I stayed in my 45 minutes. These are the conclusions. So the cerebral oxygenation is not often monitored, okay? And that's a shame because we have several techniques, and some of them, it's true, are invasive and probably not always indicated. But for example, the NIRS is a non-invasive and safe method to assess cerebral oxygenation. In brain injury, most of the time it is monitored using invasive techniques, but probably it's time to consider, even in not primarily brain injury patients, that monitoring can give us information and can be safe and can be used at the bedside of the patient. Thank you very much.
Thank you. Thank you, Chiara, for your brilliant presentation and once again for your terrific effort to be with us by Skype. I think that we may have a couple of questions from the attendants. If someone wants to ask or discuss some issue with Chiara. Probably not. So, Chiara, you can stop to share your screen now, and you just appear. Okay. So, great. So we can see you perfectly. And I want to ask you something, something that I'm going to address in the afternoon, but anyway. What do you think about the value of NIRS technology to decrease the postoperative cognitive disorders, namely delirium and POCD?
So, thank you for this question. I think this is a very good point, and it's been largely studied, actually. So, the point is that intraoperative values of desaturation are associated with an increased risk of delirium. The point is that it's not just the magnitude of desaturation, but it's the trend. What do I mean? I mean that probably it's not that important if for a couple of seconds we have an episode of desaturation, but of huge desaturation, but if we have even a mild desaturation, but which persists in time, this is definitely associated with a poorer outcome and delirium. Now, latest paper are actually describing that it's not just the intraoperative values of cerebral saturation, but also the postoperative values. So, in the postoperative phase, in day 1, day 2, up to day 3 after surgery, if you have episodes of desaturation, mostly related to hypotension, well, you have an increased risk of delirium and length of stay, of course.
Thank you. Imagine that you have a cheap sensor of NIRS available for daily use.
Yeah.
Do you think that you would use it for every patient or a wide range of patients? Very small group of patients?
Honestly, I would use it for a wide number of patients. So what I was saying, talking about neuromonitoring, the only issue with the neuromonitoring technique is whether they can give some, if they are contraindicated. ICP is the mainstream of our neuromonitoring. but we cannot put an intracranial pressure to all the patients. And so is for the PbO2, which is invasive. But when you have non-invasive methods, I'm talking about NIRS, transcranial Doppler, or whatever, I can't see any reason why you shouldn't use it. Of course, you need to be well aware of the limitations of these techniques and what they are looking at. But if I had a very cheap probe, I think I would put it in every general ICU patients, including ARDS patients, to assess, for example, the risk of neurological complications. I will put it in septic patients to assess the risk of septic encephalopathies. I would be very curious to see what happens during the recruitment maneuvers, for example, and so on. I mean,
I've been using a lot in spine surgery, mainly in old patients, and we have some neurosurgeons still asking us for relative low blood pressure to have better operative fields. So I found very useful to use niche sensors to guide or to allow us to see the thresholds of these blood pressure management. Do you think it makes sense for you?
It does make sense a lot. In the intraoperative settings, I would probably use in every patient, not in a wide range. Spinal surgery is a good example for another application that I generally use in my clinical practice is in patients undergoing pneumoperitoneum and Trendelenburg position. You know, these are basically related to increased CO2, increased ICP, probably hemodynamic instability, and there probably could be absolutely useful. Or what we were starting to do in Cambridge is in the patients undergoing orthopedic surgery, like shoulder surgery, which are basically put in a beach chair position. And there are a lot of post-operative complications, and nobody knows why, but basically it's because probably when they go in the beach chair position, they have episode of hypotension and probably cerebral deoxygenation, and that's the reason.
Okay, thank you.